Thank you. So already I suppose we've heard about some of the surgical and conservative approaches to dealing or managing FAI. So I'm just going to kind of progress on that a little bit, bring in kind of the importance of collecting regular outcomes, and just introduce some of the more recent randomized controlled trials that have been published to date. So evidence-based research, as a term, I suppose it's all-encompassing. We want to know that a particular treatment is working for an individual, but also we want to know why it's working and how it might be more effective in some patients, but maybe not others. And to date, I suppose thus far, like the optimal indications or the indicators for either a surgical or a conservative management approach are still controversial. So outcomes, there's a huge importance and a huge benefit on being able to highlight the outcomes from treatment. So prospectively collecting and analysing outcomes alongside a particular treatment intervention is one approach to substantiate, I suppose, that the effects that has on a particular patient group. As Mr. Carter mentioned, patient-reported outcome measures typically consist of validated questionnaires completed by the patient at various points throughout their treatment. And at the Hip and Groin Clinic, we use joint-specific outcome measures such as the Harris Hip Score, the WOMAC, as well as also the SF36, which is more generalised health and well-being questionnaire, and UCLA activity scale. So it's important that every aspect of the patient's physical and mental health is captured. You can also measure the success of a particular treatment in terms of patient's subjective report of how they're actually doing. Is it working, yes or no? And also in terms of return to play and overall survivorship. So more recently, there has been kind of an evolution in the terms which we use to quantify what constitutes a meaningful outcome. So these terms are generated directly from scores generated from the outcome measures, coupled with a patient's subjective feeling of how well the improvement has been. So we've got like minimal clinical important difference, which is the minimum level by which you'd expect a patient to improve by in order to have a minimal important improvement. And it works up then, I suppose, to pass, which is more of an acceptable symptomatic state, to a substantial clinical benefit, which would be a large improvement in the patient-reported outcomes. And it kind of gives us a gauge of how effective a particular treatment is in an overall population. So it's important, I suppose, for both the clinician and the patient to have a kind of a target to meet. But they do have their limitations, and we've extended on these various different terms and introduced what we call the percentage of possible improvement, which may be more beneficial for high-performing athletes in that it doesn't have some of the restrictions that the other ones do. And this was published just last month as well, and it'll be out in January for you all to read. So a quick internet search then, I suppose, on either the surgical or the conservative management approach to FAI will highlight that the research is very much weighted in terms of the long-term follow-up and the reported outcomes from a surgical point of view. And this, within the literature, I suppose surgery may have certain advantages in that it's generally kind of a one-off event, so the patient's compliance is not an issue. But aside from that, and I understand how difficult it is to collect outcomes and to regularly follow up patients, even within a well-funded outcomes unit. But in many cases, I suppose physiotherapists work in private practice. They deal with a spectrum of different issues. So recruitment and maintaining specifically FAI patients in a large enough quantity for a meaningful study to be done is more difficult. And then you've also the issues such as crossover, which I'll touch on now in a bit. So the randomized controlled trials, and Willie introduced one of them there earlier on. These have primarily evolved in hospital settings, and there's three that are published to date with specifically comparing the effectiveness of surgery and physical therapy for FAI. So the first one was published in the American Journal of Sports Medicine in 2018, and the overall conclusion of this was there was no difference between the groups, but there was certain limitations with the study, the main one being the 70% crossover from physical therapy to surgery after about 200 days. And the Centre of Evidence-Based Medicine would suggest anything over 20% of a crossover may invalidate the results. So there's other issues with the groups. Group sizes were different. The symptom chronicity was different. There was a longer term duration of symptoms in the surgery group compared to the surgery group, and we've already heard that anything over 2 years will generally lead to poorer outcomes. This one is the part of the FATE study group based in the UK, and it was published in 2019. The overall conclusion with this was that the patients with symptomatic FAI achieved superior outcomes with hip arthroscopy compared to physiotherapy or activity modification. Again, there was limitations. It was a very short follow-up, just 6 months. There was no quantitative imaging measurements used, and this may be more important for longer term in that there was one study in 2013 which said that you had a 53% chance of developing osteoarthritis 5 years down the line in the presence of a CAM deformity. So, if we don't have any kind of measure or understanding of the bony deformities within this study, it's hard to justify the outcomes. Again, it was a 94% isolated CAM cohort, which is not really typical of what we'd see in the clinic. And the last one then was the UK fashion one, which Willie mentioned. So this again, it concluded that both physiotherapy and activity modification and hip arthroscopy both led to an improved hip-related quality of life, but the hip arthroscopy led to a greater improvement. Again, limitations, we've got a surgeon, it was a multi-surgeon, multi-centre group, and it was a 12 months post-randomisation follow-up, which is different to 12-month post-intervention follow-up. In many of the cases for the surgery people, there were only a couple of weeks actually after their surgery by the time the outcomes were taken. And this was presented at the International Society of Hip Arthroscopy meeting just there last 2 weeks ago. And that gap is getting bigger, so there's a 23% crossover now, 12 months since this was published. Again, jeopardising potentially the results that was originally presented in future ones. So what does it all mean? I suppose there's still much to be learned about the indications for optimal management for FAI, and this is something that we are very focused on in the clinic, and we regularly follow up patients. And this year, I suppose, is going to be particularly interesting in that we've come up to the 10-year outcomes stage. So randomised controlled trials are pretty low quality for both surgery and physiotherapy currently, with crossover, as I mentioned, being particularly problematic. There is an appropriate role, obviously, for both management techniques in the appropriate patient. So, understanding how an intervention works is pretty key. Going forward, the future direction would be, I suppose, to establish a sports medicine network where the national consensus could be developed from a physiotherapy standpoint and specific to GA athletes, who are the main affected athletes that, we'd all see. Validated physiotherapy programs then could be developed with an active research input in order to establish what would be more beneficial for the active athlete.